Thank you very much, Dr. Muhammad. It is my great pleasure to be with you and with Banha intensive course, and it's very nice. And this course is now get what we call the more people is coming and attaching to it, and they have a very nice idea about this course. Also, it is my pleasure to be with Dr. Ibrahim from Ireland, Ibrahim Kamar, and it is the first time to be with him in visual course. My talk today is just a small bone, but it is very important, and it is. I'm going to say hello. How are you? If you not know Arabic, and Assalamu alaikum if you know Arabic. Radial head fracture in adult, it is the objective of this talk. It is anatomy and biomechanics. What about the epidemiology and the classification and the complex pattern of injury and treatment algorithm and the longer-term outcome? This is our objective from this talk. Radial head is represented like a ring, like okay. If this okay, it is okay. If you have a fracture, and if it is not reduced okay, it is will not to be okay. So it is will injure the elbow and make a disability. The epidemiology from this fracture, it is accounting about 1.5 to 4% of all fracture in adult, 33% of all elbow injury, 1/3 patient-associated injury to the shoulder, humerus, and forearm, and the rest and the hand. Rarely in children due to the cartilaginous nature of the radial head and the radial neck fracture, more common in children. This is some things you have to put it in your mind. This is an isolated radial head fracture. Davidson et al. In 1993, presenting 111 patients with entire radial head fracture had associated wrist or elbow ligament injury. 30 to 70% associated injury in various studies. Rookwood and Green mentioned that assuming associated injury unless proven otherwise. If you have a head radius, you have to assume that there is an associated injury unless proved otherwise. The entire radial head fracture or displacement, partial radial head fracture always associated with ligamentous injury. Also, it's possible to get isolated radial head fracture in elderly, but it is rare. This is mentioned by Rookwood and Green. Some anatomy and about the head radius, and the head radius is articulated part of the articulation of the elbow, and always is articulated with the capitellum and also with the proximal end of the ulna. This is the attachment of the radial head and the muscle traveling. About it, the common origin of the flexors and the common origin of the extensor, and also the anatomy from the lateral collateral ligament stabilizing factors and the medial collateral ligament stabilizing factors. This is anatomical of the elbow, and this is a cadaveric dissection. And always mention that they found that the radiocapitellar joint transmitted about 50 to 60% loading across the elbow. The head radius surgical anatomy is very important. It is valgus stability, important for valgus stability. Also the posterolateral rotator stability, and always for helping for longitudinal forearm stability. If it is disturbed, it will lead to what we call the elbow in forearm instability. This can be occurred by along with the interosseous membrane and distal radioulnar joint. The elbow stability primary stabilizer is medial collateral ligament and ulnar humeral joint. The second stabilizer is the radial head and the radiocarpal joint and the capsule. This is a section for the anatomy and the relationship of the radial head to the ligament and the tendon of the biceps and the articular capsule. So the stabilizing factor for the radial head and the elbow is static stabilizer or dynamic. The dynamic, it is anconeus, triceps, and the brachialis. But the static stabilizer is ulnar humeral joint, medial collateral ligament, lateral collateral ligament. The second stabilizer for the elbow is radial head, a common flexor organ and a common extensor organ of the muscle, and also the capsule. This is the diagram show how the stability and the big triangular by the ulnar humeral articulation, anterior and the anterior bundle of the medial collateral ligament and the lateral ulnar collateral ligament. In between the radiohumeral articulation, the flexor tendon and the extensor tendon. What about the muscle around the proximal, attached to the proximal end of the radius, is the supinator attached to the proximal radius, and the biceps tendon attached to the radial tuberosity. It's very important, the relationship of the posterior interosseous nerve, which is most common at risk for the injury. The posterior interosseous nerve travel from the anterior to the posterior through the supinator muscle, and all of the check for pre-operative for active finger extensor. It's very important during surgery and during the trauma to examine the active extension of the fingers. What about the mechanism of the injury? This can be occur direct or indirect, but the most common is indirect injury. Axial load through the pronator forearm with valgus injury and posterolateral rotatory load. This diagram shows how the steps of the injury by falling on outstretching hand, transmitting compression force to the radial head against the capitellum, and then with valgus strain leading to lateral collateral ligament, medial collateral ligament, and then olecranon fractures. This is a mechanism of falling on outstretching hand. The most common, this is the distal radius transmitting to the distal radius through the interosseous membrane of the forearm, radial head impaction against the capitellum, and then valgus injury to the elbow and the direct injury. The medial collateral ligament rupture and olecranon fracture injury lead to unstable agents. This mechanism is very important to know about the interosseous membrane. The disruption of the interosseous membrane due to actual shortening of the radial, producing longitudinal tractions. Always when you have a head radius, looking for associated injuries. This associated injury can be either ischial, which is a fracture of the head radius with inferior radioulnar joint with interosseous membrane, elbow dislocation, capitellar fracture, coronoid fracture, and more. Also look for the injury of the medial collateral ligament due to valgus stress or olecranon and fracture dislocation. This always can be associated with fracture head radius. And for diagnosis, it's very important to take a history. The history is following an outstretching hair or direct injury. When you examine the patient, looking for the swelling, ecchymosis, also for anconius triangular fullness, and this is the ecchymosis of the elbow, and this is how the swelling of the elbow. Range of motion restriction because there's a fracture, and also for stability and active finger extension for the posterior interosseous nerve. This is anconius triangular fullness, which is representing if there is an effusion in the joint. The forearm interosseous membrane tenderness or wrist tenderness, then this patient has ischial injury, means that there is a disruption of the interosseous membrane. And to detect the associated injury, examine the distal to the wrist to detect any abnormality in the distal radioulnar joint. Also, when you examine, you have to examine the interosseous membrane for fullness. Even minor fractures are painful due to hemoarthrosis. So document the forearm rotation after local anesthesia injection to joint to the joint to rule out the mechanical block to exclude other problem with fracture head radius. And you have to document it. This is documentation very important when you have a head radius for the medial collateral ligament. And this can be examined by stress film or posterior interosseous nerve, and this is the loss of extension of the finger, or distal radioulnar joint with a tenderness or abnormal mobility or tenderness as a distal radioulnar joint, and the interosseous membrane by compression test along the forearm. When you have this patient who is suspected, you have to send him for an X-ray, and this is a routine X-ray, standard anteroposterior and lateral X-ray of the elbow, and oblique green span view, and we'll speak about it in the next slide. And the forearm and the wrist X-ray is required. So it's joint above and joint below. And this is a bony landmark and how you do an X-ray. This is what we call the green span normals. It's called the radiocapitellar view. It is a lateral view, but the tube is bended for 45 degrees, and you will see clearly the space, the head radius, the capitellum, and the space in between, so you can detect any abnormality in these views. The X-ray finding, this is radiological, and you have to read anatomical radiology, the medial epicondyle, the medial condyle, lateral condyle, radiocapitellar view, and the space in between, and the radial tubercle. And this is the trochlear groove and the capitellum, which is represented as a ring. And this is very important because this is a landmark for a lot of anatomical consideration. And this is the radial head fracture, can be seen by head radius transcapitellar view. This is two lines, very important. You can do it to exclude any fractures. The anterior humeral line, passing from the anterior humeral line, passing through the trochlear groove or trochlear, and the radiocapitellar line, which is passing through also the center of the trochlea, through the capitellum. Also in the lateral view, you have to see the posterior fat bed sign, which is representing a hemoarthrosis of the joint. It can be anterior or posterior, and this is an anterior fat bed signs which can be detected there is a serious injury. Also, it's very important to take a CT scan, and this CT scan can give you a good idea about the type of the fracture, the displacement, and the heading injuries. What about the MRI? Do you need the MRI to do for any head radius fracture? Yes, this is a study by using 46 patients of the elbow with radial head. They found that there is a capitellar injury in 8 of these 48 patients. So sometimes you can detect an abnormal injury, and it cannot be seen by CT or by X-rays. Also, the pattern of injury in the X-ray give you an idea about the severity. For the dislocation, look for the dislocations at radial head fracture. Look for triple triad. This is with dislocation. Also from other disruption injury like anterior or posterior xiphoid fracture and dislocation, and the varus and rotational instability can be detected by the X-ray, indicating the severity of these injuries. When you have a classification, this classification either simple, which means that ideally for the simple for the bone only, and if it is complex, it means that this patient has an either associated another fracture or associated ligamentous injury. This is the classification by Mason, which is classified into 3 groups, but Hitchcock making the 4th group, and going from minimal displacement to displaced more than millimeter, comminuted fracture and fracture dislocations. This is one modification by Mason classification of the radial head fracture, which is classified into type 1, 2, 3, 4. We'll go through it one by one. This is type 1 is minimal displacement radial head fracture. No block to the forearm rotation can be treated by non-operative treatment. This is an example of type 1 modification of Mason classification. Type 2 will displace partial radial head fracture that blocks the forearm rotation. Entire radial head fracture amenable to fixation, treated is by open reduction internal fixation, and this is an example of the type 2. What about type 3? This is a comminuted entire radial head fracture, not amenable to fixation. So this is treated by either radial head excision or replacement by radial head arthroplasty. This is the comminuted radial head can be either undisplaced or displaced, and this is paper published for this radial head. Also, the associated or documentation of associated injury is very important. As we mentioned before, when you examine or you have a patient with a radial head, like for articular injury, like coronoid process or a cranium, ligament injury was medial collateral ligament or lateral collateral ligament or distal radioulnar disruption. What about the treatment? The goal of the treatment is correction of any block to the forearm rotation, earlier range of motion of the elbow and the forearm, stability of the elbow and the forearm, prevention of secondary osteoarthritis of the elbow. This is the goal of the treatment of the fracture head radius. So the treatment option we have for this kind of injury, either non-operative, we will mention about it, fragment excision, removal a part of the excision, radial head excision completely, internal fixation of the fracture head, or allograft implantation or arthroplasty. We'll go through one by one to know when the indication and the contraindication. So the decision making for this treatment to use one of the mentioned type of treatment is either the fragment number, displacement of the fracture, the articular surface is it intact, age and bone quality, is there any dislocation, associated ligament and injury, associated elbow fractures. Non-operative treatment, this is always indicated in the Mason type 1 fracture, Mason type 2 without block or articular incongruity can be used as a non-operative treatment. The fracture less than 1/3 of the articular surface and the lateral displacement, lateral displacement. This is non-operative treatment either by a sling or plaster slab for 3 weeks with early active mobilization of the elbow. But you have to be considered if there is a persistent pain or inflammation or contracture suspected, the capitellar fracture occur in this type of type 1 fractures. This is a paper mentioned about the management of Mason type 1 radial head fracture. We use aspiration within 6 hours, embolization, active mobilization, follow-up at 1 week, and the clinical and neurological review in 6 weeks. What about the operative management by over-reduction and internal fixation? There is an indication for that as Mason type 2 with mechanical block displacement, our large fragment more than 2 mm, our Mason type 3 where the over-reduction visible, our mechanical block to the motion like, and you can do examination by lidocaine injection as a local anesthesia, or the presence of other complex ipsilateral elbow injury without metaphyseal bone loss. The fragment excision leading to instability. So it is very important, try to preserve the smallest fragment as much as you can to avoid the instability of the elbow. This is the radial head fixation, can be done in Mason type 2 and type 3 using lateral approach. No more than 3 fragments can be using a small screws, Herbert screw, low profile, special plate, safe zone, very important, and we will speak about the safe zone and ligament associated injury, you have to repair it. This is which implant to use, either many fragment screws, 2.4 to 2.7 millimeter, we have to have countersunk, headless compression screws can be used like Herbert screws, low profile plate, mini T-plate, but in the safe zone and in the posterolateral, and you can use K-wires. This type of the implant, and you must remember that you inserted in the safe zone. What is about the safe zone? This is a safe zone presented by Smith and Hotchkiss. It is about 90 to 100 degree arc on the posterolateral aspect of the radial head. With the wrist in the neutral, the zone lays between two longitudinal lines drawing from wristal tubercle and the radial steroid process. This is the safe zone, and you can use it for fixation and implantation or using the plate or screws. This is an implant selection. You can use one of these implants for reduction and fixation of the head radius. This is anatomical consideration for different type and low profile type of implant available in the market. This is another long-term outcome of over-reduction and tendon fixation. The long-term result demonstrated no appreciable advantage over the long-term result of non-operative treatment. This is an over-reduction in 10 patients. The scoring was the same. And this is an example of the cases with the head radius, lateral exposure, and fixation in the safe zone by screws, ordinary screws. This is another study by one table reconstruction. We take the head radius outside, reconstruct the outside, and replace again. But this can be lead to a vascular necrosis. What about the exposure? We have many types of exposure to the head radius using coupling direct lateral approach. This coupling lateral direct approach is going through the interval between the extensor digitorum and the extensor carpi radialis brevis. Keep the forearm pronated to protect the posterior interosseous nerve. The posterior interosseous nerve presented approximately 2 centimeters. What about the advantage? It is no disruption to the lateral ligament complex of the elbow, but the disadvantage is the posterior interosseous nerve always at risk because it's about 2 centimeters nearly to the head. The other one, which is the most common, and we use it as a cochlear posterior lateral approach. It is the interval between the extensor carpi annalis and the anconius. Keeps the forearm pronated to protect the posterior interosseous nerve. What about the advantage? Less of risk of the posterior interosseous nerve than the coupling. At this advantage, the lateral ligament complex may injure, leading to instability. This is another approach by Hotchkiss approach directly through the extensor digitorum commands. Always the pronated for always remember pronated the forearm with fixation. Why fixation? It's very important. So that's why I'm saying to you, please, always when you would go for fixation of the head radius, make it with the forearm pronation, because the posterior interosseous nerve at risk when you do in supination, but in pronation, always the posterior interosseous nerve may be in the safe zone. So this is the safe zone of the radial head fixation, the longitudinal line between the wristal tubercle and the radius steroid process. It's very important to know about this safe zone for fixation of the head radius. What about the complication of over-reduction and tendon fixation? This complication can be classified into early or late. The early it is inadequate fixation, hardware malposition because you put it in not in the safe zone, injury to the posterior interosseous nerve, head mismatching when you do it, or delayed healing and non-union and maybe osteoporosis. What about the late complication of the over-reduction and tendon fixation? Hardware prominence because you use low-profile plate, elbow stiffness, which can be due to arthritis, needed for plate removal about 6 months, and the lateral collateral ligament repair. Loss of the terminal extension of the elbow due to the fixation. What about the radial head replacement? This is another line of the treatment. The head radial replacement is to prevent the proximal migration of the radial head, because it is very important when you remove the head radius, there is a migration of the head radius due to disruption of the interosseous membrane. And we'll speak about tomorrow about the forearm instability. Indication, extensive comminution of the radial head and excessive bone loss, elbow instability, extrapestular lesion, coronoid fracture, elbow dislocation, collateral ligament injury, and olecranon fracture. This is the radial head arthroplasty, always indicated in Mason type 3 and 4. 1/3 of the head not amenable to fixation, associated ligament injury, and coronoid and olecranon fracture. Late reconstructive non-union fixation failure and loss of the forearm rotation. What about the radial head? We have many types, like silicone prosthesis, the instability and the destructive synovitis can be, this is a disadvantage, and now it is not be more used now. What about metallic prosthesis? It is a brace fit, either brace fit or cemented, or by smooth stem, or unipolar or modular bipolar head. This silicone rubber prosthesis are now no longer used, not sufficient rigidity prone to the fragmentation. Late inflammatory synovitis is the disadvantage of this type of silicone rubbers. What about the radial head? The modern implant can be classified into unipolar or bipolar, monoblock or modular, anatomical or non-anatomical, cemented or brace fit. The difficulty for this radial head arthroplasty is how to choose the correct diameter, and also how to choose the height, also the medial offset of this implant, and the cervicocephalic angulation, how to make this like anatomical, like ordinary head radius. Bipolar permit an automatic position of the radial head with respect to the neck and the opposite articular surface. This is the radial head replacement prosthesis, a loose stem prosthesis, and that act as a stiffer spacer. The smooth stem, it is can be used, act like a spacer, produce radiolucent but asymptomatic, no over stiffening of the radiocarpal joint. What about the fixed stem? If you use the fixed stem, this will lead to over stiffening of the radiocapitellar joint if the prosthesis is more than 1 mm proximal to the coronoid process. Also, the disadvantage, open up elbow as on the lateral side, capitellar wear and synovitis. So the exact size must be done. No significant difference between monopolar or bipolar head. This is a study comparing the study of the internal fixation and the prosthesis, but they found a good, excellent result, about 92% of the prosthesis and 12% in overreduction. This is an overreduction internal fixation for radial head replacement, a complication rate for a radial head replacement about 13%, but for the overreduction about 58%. Satisfactory rate about 91% over this period. This is a study systemic review of meta-analysis of clinical outcome for this patient. Mason type 1 best treatment option is overreduction. Overall success rate about 98%. Mason type 3, 92% success of overreduction. Mason 4, the best result after overreduction followed by resection and implantation of the prosthesis. Primary implantation should show better outcome in type 3, 80%, and 82% comparing to the secondary implantation. Bipolar prosthesis is this is cemented into the neck of the radius. The complication will always over stiffening of the joint, capitellar wear problem, and the malalignment instability can be occur. The complication of replacement can the post-operative infection of the implant, like any arthroplasty. Also the main complication over stiffening with open up, ulnar nerve and posterior interosseous injury, immediate post-operative dislocation, recurrent instability, heterotrophic ossification can occur, and contraction with stiffness, which is a common problem. This is over stiffening with opening up of the radial head. Always, this is tips. Always don't forget that radial head should be in the line with the proximal edge of the lesser sigmoid notch to avoid over-stiffening, and always do this test during the examination is a radius pull test. The change in the ulnar variance less than 3 millimeter, rupture of the interosseous membrane, more than 6 millimeter, both TFC and interosseous membrane are disrupted. This is a CT scan showing the relation of the head radius to the ulnar. What about the allograft reconstruction? It can be used for the treatment or replacement of the comminuted head radius. And this is a study done by Robert Turner about replacement of the radial head. And what about fragment excision? The fragment excision, if you have a small fragment and making a mechanical radial head fragment or cartilaginous piece, not always visible in the plain X-ray, this fragment can be coming from two parts, either fragment less than 1/3 of the radial head or fragment 1/4 or 1/3 of the capitellum. So this fragment can be coming from either from the head or from the capitellum. Radial head excision, completely excision of the radial head, indicated in low demand sedentary patient and delayed sitting for continuous pain and isolated radial head fracture. Contraindication in children, the presence of destabilization injury like ischial and fracture dislocation, or triple triad. This is a contraindication for radial head excision. Radial head excision is avoided acute excision because you need to helping repair or healing of the interosseous membrane. No in ligamentous injury, 3 or more fragment, comminution of the radial head neck in elderly and low demanding patient as a salvage procedure. What about the radial head excision disease advantage? Always there is a chronic ulnar wrist pain, always there is instability, elbow stiffness, loss of the strength, degenerative arthritis, cubitus valgus, heterotrophic calcification, and always myositis cervicalis. This paper about 150 radial head excision, the 25 patient, they show an excellent result, 4 patients good result, 1 patient show fair result. What about complication of excision? The proximal migration of the radius, this leading to inferior radio-ulnar joint disruption, and this will lead to pain, weakness of the wrist, joint instability, decreased field strength, and cubitus valgus. And excessive proximal migration required radial ulnar synostosis as a treatment. Well, the biomechanic for that is the force we mentioned about 60% load applied to the hand, stability about 30% resistant to the valgus stress. So if the head radius disrupted, there will be second stabilizing medial collateral ligament deficiency and rotating motion of the forearm. This is the biomechanics of the head radius resection. And this is the proximal radial drift following the radial head can be a medial drift or posterior drift, which leading to impaired end function of the hand. The proximal radial drift following radial head, and this is 13 patient with radial head excision. But if the excise more than 18 millimeters, significant migration both medially and posterior. But if you remove more than 2 centimeter radial head resection, there is a posterior draft. So we have 2 types of draft, either medial posterior draft and posterior draft. Only with dislocation, there will be worse function outcome. This is in conclusion with a moderate implant and technical fragment excision and overreduction and arthroplasty, all of good result. Radial head excision has become a less favorable treatment option. Individualized treatment in complex cases with ligament injury or associated injury. So this is the algorithm. If you have undisplaced, so immobilization, sling, and early mobilization. If comminuted and displaced, if you have low demand elderly or low demand go for excision. If the patient is not elderly and no demand, go for replacement and this is the indication and the contraindication. And if it not go for fixation and soft tissue reconstruction. ده انا انتهيت واشكر الدكتور محمد. بس بوريكم دوت من الحاجات، بلاش استغلال الصيادله وتقدر تستخدم ايه ده، استخدم الجيركن واستخدمه كحاجه جميله. وده طبعا ده بيوريك بقى بدون تعليق، ركب طاقه شمسيه فوق بيته وركبها مظله عشان ما تبص من الشمس. احنا سبب تعاسه الكوكب والكون. وده طبعا لسلامه الجميع. خلي المسافه متر. طبعا حطها على جوجل فراح مسميها، جاب كلمه الخل مش الخل، لان جوجل ما يعرفش خلي وخل، فخد كلمه ايه فينيجر فحطها كده. ودي طبعا من محافظه الاحساء. وده تعريف الطالب: هو كائن نصف حي شبه ميت مطحون مخنوق مقهور من كثره الضغط اصبح غبيا، وبعد النتيجه تعطل مخيلته، وبعد التخرج اصبح عطل رسميا. مهما كانت ظروفك قاسيه تذكر ان هذا الكرسي ظروفه اقصى. وفي الاخر thank you for your attention. Thank you Dr. Muhammad.
Thank you so much sir for this very interesting talk. هو بصراحه النهايه كانت يعني مشجعه جدا دكتور بهاء بيه.
ربنا يكرمك.
شكرا جزيلا استاذنا الفاضل. We are waiting for questions. Any questions for Professor بهاء? A question from me, sir. في البروستاتيك replacement, do you prefer cemented or cementless?
هو البيتر cementless عشان خاطر تقدر فيها لو فيها abnormal hanging او حصل فيها بريشر على الارتيكول سيرفيس تقدر هي تبقى replacement again. لكن cemented means that you have what we call pressure or abnormal pressure can be occur or cannot replacement. So for me, I prefer non-cemented to be as a treatment of arthroplasty.
Even in old age, sir?
In old age, as you mentioned, low demand patient, for him, you can do cemented, but I'm speaking for adult active person.
Yes, sir. Now we have questions. First question from Dr. Al-Abdin Al-Azuli. Best method for intraoperative adjustment of radial head prosthesis height?
This is depend on learning curve number one and the type of prosthesis. And as I mentioned, you have to do a line and you do a good AB. And when you see the conoid process, with the level of the head radius, number one, and look for the dead space. There is a dead space when you do lateral view by the C-arm. If this dead space is present, you mean that this head replacement is good. Also, try to preserve the head itself and take the diameter, the same diameter of the ordinary head, like comparing the bone, you take it and comparing the size of the head. So don't take oversized or undersized.
Yes, sir. Another question, Professor Bahaa: how to avoid overstuffing of the radial head prosthesis?
This is the same questions. The choice of the implant, the insertion of the implant using non-cemented type, because this gives you some element of movement, which is prevent pressure on the articular surface. And learning curve, we try to make more or a lot of this procedure until you take you make your own experience.
Yes, sir. Another question, sir. What's the difference between smooth stem and fixed one?
The smooth stem, this is a stem which is moving inside. The fixed stem, this can be used by bone cement.
Yes. How to assess the radial fragment mechanical block in the elbow in the acute phase of the injury?
you make a local anesthesia, injected liglocaine or any local anesthesia, and then try to make an supination and operation to detect this what we call the bony block.
Yes, sir. And the last question, sir, what's the dead space?
This is the space between the head radius and the capitellum. This is in the X-ray. Tomorrow we'll speak about it in what we call forearm instability.
Now we come to the end of the session of Professor Bahaa Kornah. Thank you so much, sir, for being with us tonight. شرف كبير لنا تواجد حضرتك معنا دكتور بهاء بيه، ودايما حضرتك سبورتر كبير لنا في الكورس يا فندم. فشاكرين افضل سيادتك وتواجد سيادتك معانا يا فندم. And now we will shift to the